Today, Dr. Xiang Zhang talks to us about bone metastasis. And wow, did I learn a lot. This topic is super important because if cancer metastasizes, there's a good chance it's going to be to the bone. Bones are one of the most common metastatic sites for solid malignancies. It is the most common first site of recurrence for breast and prostate cancers, affecting around 10 to 12% of early stage patients within 5 years of diagnosis. And it's very common complication of advanced breast and prostate cancer, affecting as many as 80 to 90% of patients. It's also a frequently found problem in advanced renal, lung, liver, and bladder cancers. So it's a big problem that's associated with cancer progression. And I think that's something we're all very interested in understanding better, because if cancer didn't progress, it wouldn't be a deadly disease. We'd zap it, cut it out, whatever, and it would be done. But that's not the case. Cancer cells can reappear years after an initial diagnosis and continually pop up in different locations in advanced cancer patients. In my case, I was a stage 0 breast cancer patient, which means I had DCIS, which is ductal carcinoma in situ. And it's still, even though it was stage 0 and early, it became metastatic after 13 years. And guess where the cancer went? Yep, right to my bones. And that's what makes Dr. Zhang's work so critical. He's identified why. And Dr. Zhang's lab at Baylor University has discovered that in some people, damage to a bone can stimulate a cancer recurrence. That shocked me because I had never heard that before. The damaged bone can wake up sleeping cancer cells, also called dormant or latent cancer cells, activating a previously inactive cancer. So it could have been sleeping for years, but some bone trauma could wake that cancer cell up and then cause metastasis. This was mind-blowing to me. I'd never heard this before. So if you break a bone, have a knee or hip replacement, or even suffer from early stages of osteoporosis, there's an increased risk. Doesn't happen to all people, but there's an increased risk that these latent cancer cells will awaken and metastasize to the damaged bone. At the time of my metastasis in 2020, I was experiencing osteopenia. So that's like early stage osteoporosis. And I did have some significant bone loss in my spine and in my hips, which matches up exactly with Dr. Zhang's research findings. But I have to say, when I listened to his research presentation at the Metastatic Breast Cancer Research Conference, I was already metastatic. And my first reaction was, oh no, like maybe I shouldn't be skiing anymore. But before we go and bubble wrap ourselves, we need to stop and listen to what Dr. Zhang has to say, because he's here to talk to us about why bone metastases occur, but also what you can do about it today to help lower your risk, and how he plans to revolutionize how bone metastasis is treated. Dr. Xiang Zhang is a brilliant scientist with a PhD from Columbia University and a postdoc from Memorial Sloan Kettering Cancer Center. Today, he is the William T. Butler Endowed Professor and Director of the Breast Center at Baylor College of Medicine. Dr. Xiang Zhang is with us today, and I am so grateful for your time. Thank you for coming.
Thank you for having me.
I want to jump right in and talk about some of your recent research papers, which announce a finding that is very new to me. It suggests that perhaps some trauma to bone may be associated with metastasis. Can you talk to us about your new news?
Yes, thanks. So cancer cells, when they first arrive in the bone, they oftentimes are sleeping, but the damage to the bone that incur bone repair or regeneration, that's provide a chance for these cancer cells to wake up and outgrow and become over metastasis.
So, if I'm understanding correctly, when you say kind of trauma to the bone, does that mean what kinds of trauma? If I bruise myself, am I in danger? Or are we talking big fractures and breaks? And does it connect with the impact? In other words, if you have a bigger break, is there more concern that you should have as a patient?
Yes, it's seemingly so. I think our experimental data suggests the more severe the fracture is, the higher degree the bone generation is ongoing, and then it's more likely your chance of getting cancer cells outgrow is higher as well.
Interesting. So I know that cancer patients have likelihood of having some degeneration in the bones. Does that count too? Like just the kind of smaller, I think they're like micro fractures. I'm not sure if I'm using the word correctly, but small damage to the bone, could that cause it as well?
That might have some slight and modest effect as well. In general, we think any bone turnover activities, meaning the old bones being torn and the new bones being generated, that is an ongoing process. There's a baseline level of these activities in every individual, healthy or patient individual, doesn't matter. And that's just an ongoing process. And that gives a very slight activities of stem cell activity that cancer cell can take advantage of. But obviously, the fractures will elevate this to a new level, and that is also taking advantage of cancer cells. Yep.
So, my son is 19 years old, and he unfortunately overtrained and ended up with a pars defect, which was a fracture in his spine. And I mention that because he is 19, and I think the bone healing that he experienced was far better and faster than one that if I had it at, my age of now 58 years old. Does that play a role, age and your body's ability to recreate bone?
We don't know that yet. Our data does not have age as a factor, but it's certainly the healing rate and how bone heals is correlated to the age. That's absolutely correct. So I think further study will be needed to elucidate that.
And what if someone was to be thinking about elective surgery like a knee replacement or a hip replacement? And I say elective loosely because for some of those people, it's really necessary for their mobility and their lives, like quality of life. Does that cause a problem potentially as well?
So our data does not specifically focus on that kind of situation, but if what we are hypothesizing is correct, I would predict anything like that will also have this modest increase of risk of having any latent cancer cells back. But that said, that should not offset the benefit that comes with those procedures, especially when that benefit is absolutely necessary for patients.
Right. I like to talk to the listeners and share with them that, there are so many different choices you can make in your life to outperform cancer. Like, for example, doing exercise. They now feel very confident that you get a 30 to 50% risk reduction in cancer recurrence when you have regular exercise. So while we're talking about perhaps an elevated risk with bone fracture and things of that nature, I want to point out that there are other things that you can do to also minimize it. And if you're talking about a knee or hip replacement because you need the mobility, one risk factor might be 30% one way and the other 30% the other way. And so all of this is about making kind of a conscious choice to, for your best health and your best outcomes. But to me, awareness of the issues, awareness of the risk is important for making those decisions.
Yeah, I absolutely agree. I think just as you mentioned, physical activity, exercise has already proven to be a very big risk reduction factor. So that definitely will, overcome a lot of the negative impact we just mentioned about bone turnover. So I agree with you 100%. I think patients should be aware of this modest increase of risk, but that should not prevent them from doing the necessary exercise and other beneficial activities.
So, what are we talking about in terms of risk here? Do we have any statistics that we're thinking might be a specific risk factor?
Yes, based on a recent epidemiology study, that data was based on over 84,000 patients. Among those, 16% of patients have fractures after diagnosis of breast cancer. And if you look at those patients, there is on average an 18% increased risk of developing bone metastasis afterwards, after the fracture. So basically, this is statistically significant, although it also gives a rough idea about how much increase we are talking about. It's 18% of developing bone metastases.
So 84,000, that's a very big sample size. Most research doesn't have the luxury of having a sample size that big. So that's pretty nice that they were able to do that. And so the 18% is statistically significant. So we feel pretty confident that that's in the right ballpark.
Yeah.
So Dr. Zhang, how quickly might we see metastasis if a bone fracture occurs?
Based on our experience, the recurrence of breast cancer patients, there's a 2 peaks after surgery. There's a 3-year peak after surgery. That suggests that was the immediate takeoff of any residual cancer cells to the level of the clinical symptomatic level. And there's a later peak, which suggests cancer cells that live longer, latent for a longer period of time, and then take off later. So if you take that data, the prediction is within 2 to 3 years, you will be able to see overt metastasis after fracture.
And so if someone's trying to be vigilant with screenings, it's that first 3 years that's kind of the most critical time to be getting those screenings on time and making sure that they're really watchful.
Yes, that's my best guess based on the current data in the literature.
And does it ever occur like right away, like 6 months, like super fast?
Yeah, that could be happening too, because
Really?
different people's cancer cells are different and situation different. So I think within 3 years is a general period of time, but it can be at any time within this period.
So are there things that might further elevate that risk? So for example, I'm HER2 positive in terms of the subtype of my breast cancer. If someone is ER positive or maybe triple negative, does that impact this as well?
That's a great question. In general, ER positive breast cancer are more inclined toward metastasizing to bone. So we call this bone tropism. So compared to triple negative and HER2 positive patients, in general, ER positive breast cancer patients are more likely to develop bone metastasis as the first site of metastasis, and in many cases, the only site of metastasis. So based on our experimental data, we think this risk should be subtype independent. However, since ER positive patients are more likely to metastasize the bone, will maybe more relevant for patients with ER positive metastasis. Yeah.
And I know that you've focused a lot of your work on breast cancer specifically, but is this something that could be true for all cancer patients?
Yes, we do believe so. We think after cancer cells arrive in the bone, they are in a very similar microenvironment, and there are common mechanisms they use to thrive in that new environment across different cancer types. So we do think the similar mechanism may be used by other cancer types too.
And is that one of those mechanisms? I know in the research that I've done about cancer and metastasis, just for myself, you start to hear things again and again, and then which helps you understand and learn. One of those things is the mTOR pathway, which is mammalian target of rapamycin, a protein that controls cell growth, metabolism, and proliferation, if I'm correct. Is that a major pathway that we think is driving this?
That certainly is a pathway that's relevant and active in many metastatic tumors. In fact, mTOR inhibitors have been used in conjunction with endocrine therapies for metastatic breast cancer, especially ER-positive breast cancer. And a lot of those metastases are in bone. So it is used clinically, mTOR inhibitor. And more recently, there's CDK4/6 inhibitors now commonly used as well. So those pathways certainly also play important roles in metastatic cancer.
Was there another pathway that you were thinking of in particular that you've noticed in your work?
Yes. So we are focusing on how cancer cells talk to the bone microenvironment. So a little different from other studies focusing on tumor intrinsic pathways. We are thinking how to block this crosstalk between cancer cell and the bone cells. We have been identifying specific adhesion molecules, for instance, this cancer cell use to link themselves, to anchor themselves to the bones and get growth factors, also get help from bone cells to survive and to proliferate. So we are experimenting different ways of targeting metastasis. The central idea is to stop their talking to breast cancer so that it can be better cured by other treatment. Yeah.
I love that. In fact, that is why when I heard you lecture initially at the Metastatic Breast Cancer Research Conference, I really sparked to what you were saying, because your research and the work you're doing is really trying to not just recognize the problem, but understand how to stop it, which is, of course, very exciting from a cancer perspective.
Thank you. Yes. We are trying to find complementary approach to the current standard of care so that we can provide more options to patients.
Which is super exciting. I think I would love to have you talk to us a little bit about some of the aspects and things that people might find when they're reading your research. They go in and take a look at your papers. I know that you're talking about how bone injuries like a fracture or some sort of break in the bone can wake up latent cancer cells and cause metastasis. Yeah. What are latent cancer cells? For a patient, so often you get diagnosed, you get treated, they say, hey, great news, we don't see any active cancer cells on your scan, you're moving forward. And then next thing you know, 2 years down the road, cancer comes back. Can you give us a little information from your research on what do they mean by latent cancer cells?
Yeah, that's a great question. I think that's one of the most urgent, imperative questions that we need to answer. So we know for sure, as you mentioned, that surgical removal and adjuvant therapies to patients do not guarantee there's no metastasis at a later time, right? And that later time can be variable, can range from 2 years to maybe 20 years. During that period of time, although all the clinical tests will give you negative results, but when cancer does come back, all these clinical tests didn't do a great job. They failed to detect the latent cancer. So by latent, what we mean is asymptomatic, not detectable, and they are hidden somewhere. They're hiding themselves somewhere in the body. And oftentimes we suspect it's in the bone. And researchers, investigators in the field have started to provide insights into this. We know that many of the cases, these cells may stay very close to blood vessels, but when they outgrow, they may change their location. And that switch, that alteration of their neighborhood is oftentimes associated with the dynamics of bone tissue. And as we just mentioned, healing of the bone, regeneration of the bone, all those represent some perturbation that break the balance, break the homeostasis of your tissue, that actually also provide cancer cells an opportunity to change their behavior. There, they may outgrow. So how to predict patient at high risk of developing recurrence, how to identify those latent cancer cells, find them and kill them, remain an unsolved challenge in the field. And this is something a lot of labs, including mine, are working on.
It certainly is a big problem, right? So personally, I was originally diagnosed in 2007 with an early stage. It was actually DCIS, which means that the cancer was still in the ducts of the breast. And I had one teeny tiny area of microinvasion. That's it. And so when they did surgery, they thought that they had gotten it all. But 13 years later, I was diagnosed metastatic, and it had gone to my bone in my spine, as well as bone in my hips and pelvis and lymph nodes as well. So it something ignited it. I didn't have a bone break, but I was getting osteopenia. And so my next question is, does osteopenia or osteoporosis, does that count?
Absolutely. I think osteoporosis suggests that there's excessive of bone breaking, right? Insufficient, inadequate bone building. But that doesn't really mean that you have lower activity of bone homeostasis or regeneration. In contrast, because of the excessive activity of the bone breaking process, also osteoclast activity, osteoclast is the bone dissolving cells, and the bone making process is trying to catch up. So, and that result in an overall higher activity of bone homeostasis. That actually is based on what we hypothesize, it will increase the chance of cancer cell waking up and cancer cell outgrowth.
Cancer is so multifaceted, right? And it's such a complex disease, which is why we don't have a cure for it yet. But when you think about the layers you just described, you see even more of the complexity. Like, we know that cancer occurs more in older people, right? The incidence goes up as we age. We know the bone chances of osteoporosis increase with age. We know that exercise, where your bone strengthening and protecting the bone, actually decreases likelihood of cancer, right? Cancer metastasis. So you see how all these things start to weave together, which is, to me, it's quite fascinating how that happens.
Yes, you are right. So that's why it's important to understand each aspect. And then when we have a clear idea, each of the factors that involved in this process, then we will try to come up with a holistic approach specific to each patient, right? So specific to, hopefully we can have a model that we can predict the risk for each patient, and we can determine a window of opportunity to intervene in this process. We want to intervene at the best timing for each patient and using the most precise approach.
That would be amazing. What are the tools you're using to try to get to the personalized medicine? Is AI a factor?
The AI definitely will provide a lot of momentum for this process. And we will also need to tell AI what to consider, right? So that comes from the lab. So what we'll use to train AI, and that is something that we are trying to work on. Yes.
One of the things that we always try to do on this show is to provide patients with what to do. Okay, so we've just introduced a problem. It may sound scary, especially if you are in your 60s, had cancer in your past, and you don't want it to come back, and maybe your doctor told you have osteoporosis now. Why don't you tell us what's available today? How do patients minimize their risk of having a metastasis
Right, just continuing the osteoporosis topic, I think that we know we have existing treatment to mitigate that symptom. Like now the bisphosphonates, for instance, are widely used to treat osteoporosis. And there's clinical evidence suggests bisphosphonate do reduce risk of bone metastasis, even used adjuvantly, meaning you don't have to have active metastasis. Just use it after cancer removal can help reduce future risk of developing bone metastasis and other metastases as well. And this is particularly helpful for postmenopausal women, and because in postmenopausal women, osteoporosis is even higher, more severe health issue. And I think the mechanism also is likely to be that bisphosphonates reduce the turnover rate of the bone in general. It strengthens the bone, but at the same time, it also reduce the cycle that we just mentioned, osteoclast trying to dissolve and also bone making cell trying to catch up. And bisphosphonate reduce this cycle and strengthen the bone, but also decrease bone turnover rate. So that is available, and then that's prescribed to many patients. There's also data suggests that use 3 years adjuvant treatment of bisphosphonate in postmenopausal women indeed have clinical benefit.
I think it's really important for patients to know that, because I know when I was finishing treatment and they were saying, now we're going to give you bisphosphonate. And I said, more drugs, like, is this a good thing? And you wonder, like, pumping your body through all of these different medications sometimes makes you wonder, like, is this something I should really do? But I did take it. I did read the research, and I saw the work that you're doing and some notations about bisphosphonates too. And I have taken it. Now, the question I have is, are all bisphosphonates the same? Like, I mean, there are many different kinds. I take a shot, which is called Xgeva. Is Xgeva the same as a bisphosphonate? Is it a bisphosphonate?
No, bisphosphonate is a whole class of chemicals. And there are a few kinds are used more often than others. I believe zoledronic acid, for instance, is a very widely used one. But there are a few commonly used ones that often study in the clinical trials. I think the commonly used one in the clinic will meet the purpose.
Okay, yeah. So just follow your doctor's directions. And if they're not suggesting a bisphosphonate, then ask your doctor about it. It may be something that could help you avoid recurrence in the future.
Yes, right.
Great. One of the things that I also wanted to ask about is how hormones play a role in this. And does estrogen and estradiol play a role?
Yes, this come back to the difference between different subtypes. And ER-positive breast cancer more likely to metastasize the bone. And after they arrive in the bone, many of those still rely on estradiol. So endocrine therapy, anti-estrogen, anti-estradiol therapies still works, play a role in our treatment these days, even after metastasis occur. So, but just from a bone point of view, what I just mentioned is from cancer's point of view, right?
Okay.
The bone is also a tissue that's responsive to estradiol. As you know, the effect of estradiol on bone is very evident as the menopausal women usually develop more osteoporosis, right? It's because of the lack of estradiol. So estrogen does strengthen the bone in a way. And that may be the reason why, especially in menopausal women, bisphosphonate is more effective, because the lack of osteoporosis, bone turnover is at an even higher rate. So that just make the bisphosphonates efficacy even more evident.
It sounds like our bodies are almost working, like they work overtime. I'm not as efficient as I get older. I'm losing bone. So it's like the little engine that could, right? I got to work harder to try to build it up. Is that what's happening?
It's the first you lose bone, and the bone sense it, and the bone try to compensate, try to catch up but some reason because of this physiological change, they cannot quite catch up. So the net effect is still losing bone, but both the losing part and the building part are increasing, are accelerating, but just the one always surpass the other.
So it is. It's kind of like, I'm working harder and harder to keep bone, but I can't quite keep up.
Do it, right.
And it's through that high turnover rate that we're finding that's where a lot of the problems start.
Exactly.
That's really interesting. So what about, does collagen play a role in this? I know a lot of women my age who want to take collagen supplements. A lot of women are taking calcium supplements. Can you tell us, does collagen play a role? And then what do you think about supplements?
Certainly collagen and calcium are playing roles in how cancer cells metastasize, colonize the bone. But on the other hand, healthy tissue also need them, right? So we don't know, at least to my knowledge, we don't have any data suggest how this will differentially influence healthy tissue or cancer cell. So whether or not by reducing or increasing them, we can tilt the balance. So I think further study will be needed to study that specifically. But again, if these things are prescribed by your doctor, are advised to, I think for the health, general health, I think the patient are not recommended to change just because of the worry that they may benefit metastasis of cancer cells.
Right. So stick to what your doctor's telling you. I'll pay people out there. Stick to what your doctor's telling you. Just know that there's more research that needs to be done to better study and understand things like collagen and calcium and the roles that they play. Because this isn't cancer specific. Your body still needs calcium. Your body still needs collagen. We just don't know how the levels of those things are going to act, and if they're going to cause problems or not in your body. So, okay.
Absolutely, yes. That's right.
Well, what I love is that, while supplements might be great and those can be helpful in certain circumstances, the work you're doing is looking at some precision medicine, which is always exciting for cancer patients because that usually means that there's less side effects as well. So why don't you tell us a little bit about your new work and a potential drug that you're looking to develop that might be a future targeted therapy to fight metastasis to the bone?
Thanks for that question. And yes, my lab and my collaborator lab have been working together to enhance the specificity of drugs to go to bone, to home to bone, just like cancer cell like to go to bone. We would love our drugs also home to bone, preferentially, to overcome the bioavailability issue. Usually drugs difficult to penetrate bone. But we have come up with a new idea, modify chemically our drugs so that they can home to bone more readily, so they can achieve a higher concentration in the bone. It can also spare other parts of the body for any kind of side effects. So we have been working on that. Particularly for that. So since I just mentioned, what we love to do is to block the crosstalk between cancer cells and the bone cells. We just cut their connection. I just mentioned there's specific adhesion molecules that are doing that, right? Those adhesion molecules, unfortunately, are not bone specific. They are also expressed in other parts of the body. So when we try to cut off this connection, we only hope to do it in bone and not in other places. So that makes this type of modification of drug very important. If we can achieve that bone-specific delivery, and we can target many targets, such as this adhesion molecule, without worrying that there may be side effects in other parts of the body. So this is something we are working on, one of the several important directions we are heading toward.
That sounds amazing. Does it work with bisphosphonates?
Absolutely. So one way we can make this molecule to enrich themselves in the bone is to link them to bisphosphonates, because bisphosphonates have very high affinity, adhesiveness to the bone tissues. And linking this molecule to bisphosphonates will physically enrich these drugs in the bone, make them stay there for longer time at higher concentration.
It's interesting. I think that there is some precedent for making this work too, isn't there? Where the trastuzumab drug that I use for HER2 is similar to that. Is that true?
Yes, this is absolutely true. Actually, it's getting, I think, the next generation, the generation that been revolutionized breast cancer care is what you mentioned. It's called antibody drug conjugate, right? It's basically combine the antibody and the drug. The antibody will achieve specificity. They will target cancer cells and cancer cells only. And the drug will kill cancer cells by getting into cancer cells and induce them to die. So this is a similar idea in addition to this molecule that target cancer cells and kill cancer cells. Now we can further modify the drug so that they can only go to bone. They can go to bone in more readily, so that we can also have this tissue organ specificity.
That's truly amazing. I can't help but think of it like the Trojan horse, going in and it's like it gets to the cancer cell and then, aha, look, there's a cancer drug that's going to kill the cell hidden behind it. So bone metastasis is incredibly complex, and there are many different kinds of metastasis. Currently, treatments don't recognize bone metastasis as different, if I understand it correctly. If they are different, how would they ideally be treated? How does that work?
You raise a very important question. I think in the clinic, we tell patients about their metastasis, bone metastasis. And usually that's based on imaging, right? Based on imaging, sometimes biopsy as well. But, they are all treated the same way. The bone metastasis in one patient is considered equal to another patient's bone metastasis. We recently, in collaboration with other clinicians and scientists, have found that the metastases from different patients are actually very different, despite the fact they all come from bone or even the same bone. But if you look across different cancer types, many patients, you find that different classes of bone metastasis can be found. So there are metastases that enrich with osteoclast, with the bone dissolving cell. There are also other bone metastases that are lacking bone osteoclast, but enriching some other immune cells. So what we're finding is different, almost like ecosystems. Despite the fact they all now living in the bone, different cancers seem to evolve differently and recruit different immune cells so very clearly these bone metastases are based on different mechanisms, biological mechanisms. They will cry for different treatments too. But we are still at early time of looking into that. But going forward, definitely we will establishing different models that recapitulate these different ecosystems in patients and trying to study how we can more precisely target each metastasis.
I'm sure that's why you were talking earlier about trying to personalize each one of these. I know one of the types of breast cancer, which is cancer researchers struggle with because there's not a whole lot of treatments yet. I mean, certainly things have come a long ways, but triple negative breast cancer just has it's like an absence of targets. It's not ER positive. It's not HER2 positive. It's not even progesterone positive. So it's less targets. But I believe I read something or we discussed that triple negative breast cancer even itself has different types of, or can metastasize to bone in different ways. Is that true?
That's very true. So even for triple negative breast cancer, we know that, as you mentioned, new therapies are coming along. I mean, immunotherapy, for instance, in combination with chemotherapy, now have been used to treat advanced triple negative breast cancer. And there's a big improvement of patient survival. Although that's not enough because some patients still don't respond. And when they don't respond as a neoadjuvant setting, the primary tumor don't respond, it often also indicates that the prognosis of the patients is also worse. So clearly, even for triple-negative breast cancers, if we just thinking about how they respond to immunotherapies, and later, you will see different heterogeneity of different response and later prognosis, meaning metastasis. So this is another thing that we are trying to study in the lab. What we found is, just by looking at those patients' blood, asking, what can you find in those patients' blood that may indicate this patient response to immunotherapy? You can put different patients into 3 categories. There's one category that look just like normal, healthy individuals. Those patients tend to have very good response to immunotherapies. But the other 2 classes of patients seem to have different types of abnormalities in their immune cell content in the blood. By that, I'm not saying the simple blood count every patient will have during their visit to the clinic. I'm talking about some rare immune cells that clearly is rare in normal individuals, but they seem to be elevated to abnormally high degree in some patients' blood. We in our lab, we dig into this phenomenon. We found that the reason behind this different abnormal immune cell in blood is because the crosstalk between cancer cell and the bone marrow. Even before metastasis happen, even before cancer cell can go to the bone, before that happened, there's already crosstalk through the blood circulation. The bone marrow already sensed the existence of cancer and begin to change its function, its activities, its blood-making function. And we know most immune cells are made in the bone marrow. So bone marrow sensed the existence of breast cancer. They somehow skewed their normal activities, and that reflect the host response to the tumor. And unfortunately, some of the responses are not helping our immune response, our immune attack to the tumors. Therefore, those patients do not respond well to immunotherapies.
Fascinating.
But luckily, we now know what to look. We are trying to develop diagnostic assays, try to kind of predict the therapy response for patients beforehand, right? Before they even receive the treatment. So we can be more precisely decide, what treatment to use. And if the current treatment is not enough, what can we add to that to improve the therapeutic response?
So I'm connecting dots from different things that I've read and heard over time, and that's what I love about having these discussions, is that I feel like I'm actively learning all of the time. So I've done some work looking at how like a healthy gut microbiome helps your immune system, right? And that a healthy immune system then allows the immunotherapy drugs to actually work better for you. And so I think there was some work from MD Anderson in that space on certain types of cancer that demonstrated that a healthy immune system did benefit patients that were on immunotherapies. So when we think about the bone and we think about metastasis to the bone, and we're talking about building bone and osteoporosis and osteopenia, I don't really think about the immune system, but yet you've talked about it now a few times. So do we know exactly how the immune system is factoring into this? Does the immune system have anything to do with the turnover rate of the bone, for example?
Yeah. Yes, this is a multifaceted question, as you point out. The immune system is increasingly recognized as something important for many things, including the bone turnover, including how our host trying to fight against tumors. So maybe I can divide this into two parts.
Yes.
The first part, immune system has, to my knowledge, has been constantly trying to fight against cancer. We didn't know that until 10 years ago when checkpoint blockade therapies are used, become widely used. It's just saying that our immune system never give up. They always try their best to kill cancer cells, but cancer cells, on the other hand, also develop this ability to dampen the immune response. In many cases, weaken immune cells. Other cases may flip the roles of immune cells, hijack their function, so the immune cell becomes corrupted and even playing pro-tumor roles. But all those, if we can fix those, we can understand and fix those, our immune system remains to be the most powerful weapon against the cancer. So that's my belief. That's many other scientists and clinicians believe. And that's why we have been constantly trying to understand how cancers modulate immune response and how immune system can be helped, can be fixed to continue the fight against tumor. I do think if there's anything that can match tumors' evolvability, it's the immune system. Because our immune system are created to deal with a very complicated world, right? A lot of different pathogens. Tumor happens to be one of the most difficult ones to treat, to deal with, right? But the immune system is equipped with the capacity to fight. More specifically about, just link it back to the first topic about bone metastasis. The immune system also plays roles in this turnover rate, right? So there has been studied for a long time. There's a scientist who specifically asked what different immune cells roles are in bone tissues, bone turnover. It is a very old field now. With this bone metastasis, in this context of bone metastasis, it becomes even more interesting to ask that question. How different immune cells may alter bone turnover and therefore indirectly change the trajectory of metastasis. It's something that my lab has become very interested in. We do believe there's a lot to discover at this point. Besides that, we confirm it is important. We don't have a lot to share, but this is something very exciting to work on.
Well, it's the first step, right? I mean, we have to identify what are these rich areas that we want to investigate that we think might yield, big advances. Yes. So that's fascinating. And once again, we're just reminded, it's funny that, we get so smart about things, but it comes back to some of the things that we heard when we were kids and from our grandmothers and,
yes.
Right, about taking care of ourselves and, overall health and how we can help ourselves by just having a strong immune system. So, eating healthy, 30 different fruits and vegetables a week and getting our sleep and getting exercise to build bone and even as a secondarily, yes. Getting screenings so that we can catch anything early on.
Yes.
So I just want to focus on for a second who could benefit from all this work that you're doing. We touched on it earlier that you don't think it's just breast cancer patients. We've talked a lot about breast cancer patients because your lab has focused in that area. But if you'd expand upon it a little bit, if someone out there has, colon cancer or, liver cancer or pancreatic cancer, do we think they could benefit from any of this work as well?
Right. We do think so. We think, breast is just the one example. But since we have established model to study breast cancer bone metastasis, we learn a lot from breast cancer. But a lot of those knowledge can be applicable to other cancer types. Simple example is bisphosphonates are used to treat bone metastasis from multiple cancer types, not just breast, right? Although initial work, the pioneering work is mostly done in breast cancer models. So there are common features of this metastasis living in the bone.
Interesting. And what about, some Patients might be like, well, I'm just a stage 2 breast cancer. Should I be, worried about metastasis to the bone versus a metastatic patient that might be having some time where they are cancer-free, no active cancer in their bone? Are those two groups both able to benefit, a stage 2 person with no metastasis to bone and someone who has metastasis to the bone where that metastasis is no longer active?
For early phase disease, we don't have direct data to suggest one way or another, other than saying metastasis may happen before diagnosis, right? So a lot of time through analysis of the established metastasis, compare them to primary tumors, people have learned that metastasis can occur very early on. So when the primary tumors are diagnosed and removed, already there's disseminated tumor cells in distal organs. Of course, many of those cells will not do anything, which we talked about latent cancer cells, right? We talked about the dormant cancer cell, but a lot of those cancer cells will not do anything. But sometimes when metastases do occur, those seeds of metastasis were planted way before primary tumor is removed. So early phase breast cancer may already have seeded metastasis to other organs. So how do we prevent that? I think neoadjuvant therapies, right, is one way to eliminate those cells. And we are doing that now in the clinic. All the neoadjuvant therapy, immunotherapies, right, plus chemotherapies, indeed are trying to treat primary tumor, but they are also, if they are working, they also eliminate those metastases. So what we learned today from the cancer cell in other organs will ultimately also benefit early phase patients, but our current therapies already is trying to help them.
So you're saying that if someone, for example, had surgery to remove a cancer, and that they think, well, the cancer is removed, why should I have to have any more chemotherapy or do any other therapy? What you're saying is neoadjuvant.
Before surgery, right? Neoadjuvant is before surgery, adjuvant is after, right?
After. Okay, so early drugs and immunotherapies that would systemically be able to identify cancer cells and catch perhaps some of these latent cells that are in places we don't want to have them.
Right. So understand how those drugs work, why some patients respond, some patients do not respond. Oftentimes also indicate of whether the already disseminated tumor cells will respond or not. Okay. So therefore, how to optimize the treatment at that stage will inform how can we eliminate those metastatic cells.
And I've seen and read that there's something called, I didn't realize this when I first was diagnosed, but I've done some reading and seen that there's something called a cancer stem cell versus a cancer cell. And are a lot of these latent cells cancer stem cells, or are they both? How does that factor?
There are data in the field suggest that latent cancer cells tend to be cancer stem cell, which is not completely surprising because if you can survive so long, it got to be something that special, right? So those stem cells also comes with this viability and the ability to regenerate the population. So it's not completely surprising to see that those long-lived latent cells have some stem cell features. But cancer stem cell also is a very general term. So there's a lot of different definition of it in the field. So I think we have the among scientists, there have been discussion about how to define it, whether it's appropriate to call it stem cell or not. But I think it's safe to say there's certain stem cell features of those latent cancer cells. Yes.
Okay, interesting. Okay, that makes sense to me. That it's got at least if not completely stem cells, at least stem cell like.
Yes.
Okay. Yeah. And so that makes them a little special, which may give them superpowers to be latent for many years, in my case, 13 years, and then rear their ugly heads down the road, unfortunately, and be hiding and escaping some of the therapies that we currently have, but hopefully not be able to survive some of the therapies that people like you will be creating in the near future, which we all keep our fingers crossed.
Yeah, certainly hope so. Yes.
Well, thank you so much for your time. I'd love to just wrap up and then give you a opportunity to tell us anything else that you'd like to share and how we can support your work if there's anything coming down in the future that you'd like us to look for. I think we've learned so much from you today. We've learned that bone fractures and breaks can create an increased risk for cancer patients, and that increased risk can be mitigated by bisphosphonates and also screening to make sure that if we do have a problem, we catch it early on. We also know that exercise can play a role in continuing to help our bones stay healthy and strong so that we have less of what we're knowing the problem is, which is this bone turnover rate, this high bone turnover rate. So we have a new risk, but we also have some tools in our toolbox to fight it right now. And you're creating some new work that's coming down the pike that we're looking forward to that may target those cancer cells that are in the bone very directly, like an immunotherapy. So it would be a wonderful treatment for cancer patients because they'll have less systemic effect and negative effects on our health and quality of life. So there's a lot to look forward to in the future. Is there anything that we can do or look for in your work that's coming soon that we should know about?
So certainly, I really appreciate this opportunity to share a lot of our work. I think going forward, the first priority for us is to translate what we are doing in the lab to the clinic, right? So to do that, we certainly need, as we are doing now, to collaborate with a lot of parties, including the most important patient advocates, support from them. Also, we are seeking support from pharmaceutical companies, from other funding agencies, and trying to be able to do clinical trials, especially early phase clinical trial, so that we can really apply what we learned in the lab to the clinic, to the reality, to actually help patients. So that is something they are very diligently working on, and we hope to have some update for you in the coming year. And of course, your support will be very much appreciated.
Excellent, excellent. So when you're there and you're ready to start your first clinical trial, we'll look forward to talking to you again and letting cancer patients know what's out there for them. We really appreciate all of the work that you do. Without people like you, I certainly wouldn't be alive, and I know many others. So we're super grateful for the dedication that you've put in your life. Thank you so much for today, and thank you for your work.
Thank you. I appreciate the support from patients, and thank you again for having me today.
And now, an important announcement. All the information that was provided today was for educational purposes only. I'm a patient, just like you. I am not a licensed or accredited physician, therapist, or clinical researcher. All information provided is not intended as a substitute for the advice of a physician, therapist, nutritionist, or any other qualified healthcare professional.